All right. Thank you very much, Dr. Sai, and kudos to you for navigating the sirens and bounce music. That was impressive. All right. Here we see. All right. So next up, we're gonna shift from the surgical perspective. We talked about diagnosis. We talked about combined diagnosis and surgery. We talked about the importance of why that's allowing us to catch things at an early stage, and the potential conflict or the potential complication of upstaging if we don't catch it at an early stage. So what happens when they get upstaged? That's when we turn to our faithful medical oncology colleagues. So the next talk is going to be by Dr. Millett. He's a thoracic oncologist at Ochsner. He trained at the University of Cincinnati, where he did his residency at George Washington, where he was the chief resident, and then went on to do his fellowship at Emory. He is an accomplished researcher. He's won the ASCO Cancer Young Investigator Award for his work in immunotherapy, and we know him very well from teaching us in our tumor board, and he's a brilliant mind and a really valuable tool to the thoracic oncology program, and he's teaching us on a regular basis. So I'm excited to have him teach us here today.
All right, good afternoon, everybody. My name is Linwood Millett. Like Dr. Dozier said, I am one of the thoracic medical oncologists in New Orleans here at Ochsner, MD Anderson Cancer Center. I have a small disclaimer. My pictures and lack of videos are going to seem a little more boring than the presentations prior, but I promise that they are important, and if you turn your head just right, they might also look exciting. Here are my other disclosures. So last year at CAGLA, I gave a general overview of systemic therapy options in resectable non-small cell lung cancer. Even since that time, there have been a number of updates. I'd like to review those today. I also want to expand a little bit to include non-resectable but still early stage disease, incorporating radiation as a modality. It's a pretty big topic. Certainly can't do it justice, so I'll try to hit the highlights. I'm going to organize it first by resectable and then unresectable disease, and then also by treatment type, so immunotherapy and then targeted therapy. So we'll start with updates in resectable non-small cell lung cancer. As has been discussed, the ultimate aim of surgical treatment is cure. We know that a proportion of patients will be cured with surgery alone, but that amount or that percentage of patients decreases with increasing stage. In order to improve the chance of cure, we can tack on systemic therapies. We can do it in a number of ways, either after surgery with adjuvant systemic therapy, prior to with neoadjuvant therapy, or on either side of surgery with perioperative therapy. Last year when I gave this talk, this was the landscape. And you can see even since 2021, we've had kind of an explosion of treatment options. This has increased even more, which is very fortunate for our patients, though perhaps less so for us, as it makes it a very complicated field to wade through. And it requires that we make nuanced considerations on a patient-by-patient basis. Before I talk about any new studies, I do want to update some of the older studies. First, we'll start with Checkmate 816. So this was the first approved regimen using neoadjuvant chemoimmunotherapy in this setting. These updates that I'm about to go over were first discussed at ASCO 2025. So the study looked at upfront chemotherapy plus or minus immunotherapy with nivolumab for 3 cycles, followed by surgical resection. Patients had to be stage 1B through 3A, noting that this was the 7th edition AJCC staging criteria, so 4 centimeters or greater or no positive disease. Primary endpoints were pathologic complete response and event-free survival. And I think in many ways, as many people here can probably attest, this did kind of upend the way that we practiced with early stage disease. Previously, we chiefly reached for adjuvant chemotherapy alone. I think there were initially concerns about what this meant for surgery, where fewer people are going to make it to surgery, where surgery is going to be more challenging due to treatment effects from the immunotherapy. But I think all the evidence points to the fact that both improved surgical outcomes and overall outcomes indicate that this is the new standard of care. So we did previously have good 2-year event-free survival data, and now we have the 5-year overall survival data to further support the use of neoadjuvant chemoimmunotherapy. So there's a statistically significant difference in 5-year overall survival with a median 5-year OS of 65.4 months in the Nivo arm versus 55 months in those who did not receive nivolumab. As with the original publication, this update does demonstrate variable efficacy based on stage as well as PD-L1 expression. As you can see here, the trend towards greater benefit is in patients with higher disease, noting that there's just clearly a greater separation in the curves with patients who had stage 3A disease. In both, the confidence intervals do cross 1, but it does so to a lesser degree in the higher stage disease. Likewise, results varied by PD-L1 expression. In patients with PD-L1 negative disease, the median OS wasn't reached, but if you look at the percentages between the Nivo and the non-Nivo arm, they're pretty much the same at 53 and 52.6% respectively. In the PD-L1 positive groups, however, those numbers are significantly different. 78.3% in patients of patients are still alive at 5 years who received nivolumab versus only 57.6% in those who did not. So here is an important exploratory analysis, which is going to be mirrored by the other studies as well. We can see that there's a clear survival benefit in patients who achieved pathologic complete response. There's a really impressive hazard ratio of 0.11. This is compared to patients who did not achieve a pathologic complete response. This is an almost 90% reduction in death at 5 years, which is just a phenomenal number. There was also a trend towards improvement in overall survival in patients who cleared circulating tumor DNA as tested by a number of molecular residual disease tests. This is a really important consideration, recognizing that all comers actually benefit. So you could certainly make the case that people who are PD-L1 negative or are lower stage may not benefit as much, but we can actually see that regardless of stage, regardless of PD-L1 expression, there is a chance for pathologic complete response, and people who are PD-L1 negative or low stage and had a path CR are still alive at 5 years. In my mind, I think that this really, it means that we should consider anyone who's a worthwhile candidate, or we should consider this worthwhile for anyone who's a candidate, really. I also think it's worth remembering that PD-L1, while helpful, is an imperfect biomarker, so we need to make these decisions in a broader context alongside the patients. So how does this impact practice? Well, I think it certainly reinforces that neoadjuvant chemoimmunotherapy is and should remain a mainstay of therapy in patients who qualify. That said, great update for CheckMate 816, but we are still faced with a big question. In whom should we use perioperative chemoimmunotherapy, and in whom is neoadjuvant alone sufficient? So this past year, we did receive updates in all 3 major perioperative regimens, the schema for which you can see here. The study designs were all quite similar, varying only by type of immunotherapy and type of platinum, as well as frequency of immunotherapy administration. In all of these, patients received chemoimmunotherapy up front, then surgery, and then 1 year of immunotherapy subsequently. So we'll look first at CheckMate 77T, which is an update to nivolumab, so kind of the inheritor of CheckMate 816. Previously published data were 18-month EFS, and it favored certainly perioperative Nivo over neoadjuvant chemotherapy alone. Updates from ASCO show us both EFS and OS data now at 30 months. EFS is still significantly improved at 61% in the Nivo arm versus 43% in the chemo-only arm. And there's a corresponding trend, at least, towards improvement in 30-month overall survival. Importantly, this is kind of reflected across all analyzable subgroups, and there are no new safety signals at this time point. Now, going back to this pathologic complete response thing, and also circulating tumor DNA, the presence of both of those things portends improved outcomes, as has been shown in other studies. This is, I think, not unexpected, but it was overwhelmingly a case that patients who did not attain circulating tumor DNA clearance likewise did not achieve a pathologic complete response because there was still tumor left behind, and that just makes sense intuitively. We also see in the study that event-free survival favored Nivo irrespective of some of the bad actor mutations that we like to bandy about in tumor board, KRAS, KEAP1, and STK11. Moving on to durvalumab in the Aegean trial, updates here were provided on exploratory analyses looking at post-surgical clearance of circulating tumor DNA yet again, and then the outcomes thereof. In previous publications, it has been shown that circulating tumor DNA clearance following neoadjuvant treatment correlates with improved pathologic complete response, event-free survival, and overall survival. So looking at the updated information, it is perhaps unsurprising that patients who had molecular residual disease after surgery were those who had higher stage disease, as well as circulating tumor DNA at time of diagnosis. As with Checkmate 77T, no MRD positive patients, when I say MRD, I mean molecular residual disease, so circulating tumor DNA presence, had pathologic complete responses or even a major pathologic response, which is defined as 10% or less viable tumor at the time of surgery. While patients who had molecular residual disease were in the minority at about 10%, they did account for an outsized share of patients who relapsed or died within 1 year at 42%. This is likewise demonstrated in the 12-month disease-free survival data. So if you have persistent tumor, that is bad. Of note, authors also presented data indicating that KMT2C and KEAP1 mutated disease were more likely to be MRD positive against some bad actor mutations. There did not appear to be an EFS benefit. It was a small number of participants, but it may be a group of patients in whom perioperative durvalumab does not improve outcomes. And then looking at the third with pembrolizumab, we've got Keynote 671. We previously knew 2-year EFS data, which demonstrated a superiority of perioperative pembrolizumab compared to neoadjuvant chemotherapy alone. We got updates from ESMO 2025. We now have 5-year EFS and OS data. So EFS remains significantly improved with an EFS of 50% in the pembro arm versus 26.5% in the chemo arm. There's a corresponding improvement in 5-year overall survival as well, 64.6% versus 53.6%. And notably, this is the first perioperative immunotherapy trial that does have positive 5-year overall survival data. This is very important data. Also importantly, outcomes were improved pretty much across all groups, and again, no new safety signals. So of all these regimens, the question is, when do we use what? I don't know. There haven't been head-to-head evaluations of neoadjuvant, perioperative, or adjuvant treatment regimens. In my mind, at least, I think that the case is strong to incorporate neoadjuvant immunotherapy at the very least. It allows for improved priming of T cells against a larger array of tumor neoantigens. The T cells are able to move unhindered or less hindered through a largely undisturbed lymphatic system. And you also can avoid a post-surgical gluconeocorticoid surge, which may hamper immunotherapy effectiveness. But what patients benefit from the addition of adjuvant immunotherapy beyond the neoadjuvant chemoimmunotherapy? As you can see in this little cartoon, activated T cells do persist after neoadjuvant immunotherapy and surgery. So how much more immunotherapy, if any, is going to benefit patients? We have to recognize that immunotherapy is not a benign treatment. Ongoing receipt of immunotherapy increases the risk of immune-related adverse event at any point on time on trial or on treatment, as well as for months afterwards. So we really should pin down what patients are going to benefit the most from extra immunotherapy. It's a big question, and I don't think it's been answered yet. Should patients who have viable tumor at the time of surgery receive more immunotherapy? Do patients who have viable tumor at the time of surgery, are they more refractory to immunotherapy and therefore won't benefit? Should it be patients who have circulating tumor DNA? We don't know. So major caveat that with cross-trial analyses comes a lot of peril, so don't stone me. But when we look at outcomes between Checkmate 816 and some of the perioperative trials, the outcomes do appear relatively similar. There are no prospective studies currently comparing these two options, but there have been some meta-analyses performed. They have failed to demonstrate benefit to adding adjuvant immunotherapy to neoadjuvant chemoimmunotherapy. In one looking at 11 randomized controlled trials with over 4,500 patients, there was no improvement to EFS or OS with the addition of postoperative immunotherapy. There's another looking at 5 randomized controlled trials, same outcome. So I think while updates over the past year provide us with data upon which to build, at present, I don't think there's a clear answer to the question, and future studies will need to be performed in order to better answer it. Some of these are ongoing, and they seek to offer novel upfront combinations with the goal of increasing pathologic complete response rates as well as circulating tumor DNA clearance. In my personal practice, I still tend to reach for neoadjuvant chemotherapy alone, given that it has good outcomes, decreased costs, and decreased burden of treatment on patients by foregoing a year of extra immunotherapy. That said, I do think perioperative regimens are a very appropriate choice as well, and we haven't even discussed adjuvant regimens, which we're not going to discuss because there are no updates. So now that that isn't settled, I'd also like to draw attention to emerging data that indicate that the time of day during which patients receive immunotherapy might actually significantly impact outcomes. So the Lung-Time CO1, it was a randomized phase 3 prospective trial evaluating efficacy of immunotherapy when delivered either prior to or after 3 p.m. in the day. Randomizing 210 patients to either time block, both PFS and OS are significantly improved by earlier administration of immunotherapy, with a PFS of 11.3 months versus 5.7 months, and an OS of 28 months versus 16.8 months. This is a big difference. I think this has also been mirrored in other studies. There's the Memoir study looking at melanoma, which showed the same. There's a meta-analysis of 18 other studies with various tumor types. And that meta-analysis indicates that earlier time of day infusions could enhance PFS and OS up to 4-fold. This is, of course, it has administrative implications, scheduling, et cetera, but I do think that it's sufficiently compelling to impact practice. So moving away from immunotherapy at breakneck pace, we will discuss targeted therapy. So I don't want to start anything new. We'll just kind of rehash ADORA real fast. This was a trial that evaluated adjuvant osimertinib, which is a once-daily oral TKI for EGFR mutated disease, in patients who had a tumor of at least 4 centimeters in diameter, with or without, or with lymph node involvement. Patients had to have an exon 19 deletion or an L858R mutation. Patients could receive standard adjuvant chemotherapy before the OC and ultimately receive 3 years of pill. This trial had some really impressive data. These are some good curves. As you can see here, DFS was not met at any stage of disease treated, and importantly, this includes stage 1B disease. Remember that in like 4 slides. So one of the new trials being discussed today is NeauxADORA, which seeks to prove if there is utility in a perioperative or at least a neoadjuvant approach with osimertinib as opposed to a purely adjuvant approach. This was a phase 3 trial. It looked at 9 weeks of OC up front in patients who had completely resectable EGFR mutated disease. It had an interesting primary endpoint of major pathologic response, not pathologic complete response. There were 3 arms here, so OC plus platinum and pemetrexed, OC monotherapy, and chemo alone. Notably, and this is notable, patients were allowed to receive adjuvant therapy, including osimertinib, and in fact, 91% of patients did. So this is really important to remember with the data. So looking at major pathologic response, there is a clear superiority in both of the osimertinib-containing arms, with a major path response of 26% in OC chemo, 25% in OC alone, and a measly 2% in chemo. Importantly, this superiority appears maintained across all evaluable subgroups, irrespective of EGFR mutation type, smoking history, baseline circulating tumor DNA, and stage. The authors also presented EFS data. It's only 15% mature, at least when this was presented. But EFS rates at 12 months were 93% for OC chemo, 95% for OC alone, 83% for chemo. And so it again favors the osimertinib-containing arms. So whereas in many trials, pathologic complete response was either a primary or a secondary endpoint, in NeauxADORA, the trial was designed to detect major pathologic complete responses, again defined as 10% or less viable tumor at the time of surgery. Pathologic complete response has proven its utility when examining immunotherapy, but the utility, I think, in TKI studies is not been made entirely clear. I do think, in this trial, it's important to note that MPR status does appear to correlate with EFS based on the EFS analysis, the interim analysis. It's also worth remembering that pathologic responses exist on a spectrum. In the aforementioned immunotherapy studies, there are trends towards improvements in patients who had a major path response, if not a pathologic complete response. So besides adding yet another tool in our already considerable armamentarium, how do these results impact practice? First, it is important to note that this regimen has not been FDA approved, but I assume that it will be soon. So a case can be made for using this regimen in patients who have bulkier disease, recognizing increased chance for micrometastatic disease that could blossom after surgery. Also worth noting is that there is a significant proportion of patients who had nodal downstaging at the time of surgery. It has generally been the case that with neoadjuvant regimens, we are selecting for patients who are resectable at time of diagnosis, and we are not using medicines to downstage. However, in this case, it's something that we may actually consider. I think it's also, or finally, when comparing the rates of major path response and early EFS between the two OC arms, the outcomes are pretty similar. The question is, do the patients really need platinum doublet therapy with the OC or not? I think more mature data will be interesting. Now, another ADAURA variant, this is ADAURA 2. It's an ongoing phase 3 evaluating use of adjuvant osimertinib in even earlier stage disease. So remember, with ADAURA, there was benefit as low as 1B. So now we're looking at 1A2 and 1A3. We don't have any data yet available for this, but if positive, again, I think it will shift paradigm. Moving from ALK-rearranged disease is the ALNEO trial. Now, this was a phase 2 clinical trial looking at perioperative alectinib in patients who had resectable stage 3 ALK-rearranged non-small cell lung cancer. Patients received the equivalent amount of alectinib as they would per the ALENA trial, which is purely adjuvant alectinib. And they did this for 2 years after surgery. Again, primary endpoint here was major pathologic response. As with ALENA, and unlike the EGFR studies, there was no option for systemic chemotherapy in this study. With a major path response of 42%, so the trial did meet its primary endpoint. Other notable results, a path CR of 12% and an overall response rate of 67%. Those were secondary objectives. And median event-free survival and overall survival were not reached. So as with NeauxCancer, this is not FDA approved. As with NeauxCancer as well, it's unclear who might benefit, that we can consider the same scenario of bulky disease for the same reasons. I think an interesting question, both with ALENA and ALNEO, is whether alectinib is even the right drug. Now, there is no data yet on the use of lorlatinib in resectable disease, but the CROWN data is just so impressive, I can't help but to wonder if it will make its way on the stage soon. I'm almost done, I promise. So moving away from resectable disease, we're going to go to the still early stage, but now unresectable disease. So recognizing that immunotherapy improves PFS and OS in operable early stage non-small cell lung cancer, SWOG NRG S1914 looked to determine the utility of immunotherapy in patients receiving SBRT. So randomized phase 3 in which patients received atezolizumab in advance of, during, and after radiation therapy. Eligible patients had to have no negative disease, less than 7 meters in size, and they had to be deemed either medically inoperable or they had to have turned down surgery. Notably, the trial did enrich for high-risk features, including tumor diameter of at least 2 centimeters, an SUV of 6.2 on PET, and moderately or poorly differentiated histology. Ultimately, this was a negative trial. It closed at the first interim analysis due to futility, both for progression-free survival as well as overall survival. There were also more grade 3 or higher adverse events reported in the combination arm. Interestingly, there appeared to actually be a worse PFS in the immunotherapy arm than in the radiation arm. During the panel discussion at ASCO, it was posited that this may have been to overreading fibrosis from the radiation as actual progression. These outcomes are actually similar to another phase 3 clinical trial. It was Keynote 867, which looked at a similar patient population. It likewise did not improve EFS or OS, but it did increase toxicity. So based on these outcomes, at least for now, I think it's unlikely that we'll be using immunotherapy in advance of SBRT or with SBRT in early stage disease. I think it also proves that SBRT is pretty effective and it sets a high standard. I think another question this raises is how much stock should we put into the abscopal effect? Despite thoughts that radiation therapy might expose the immune system to a greater array of tumor neoantigens, I think there have been a lot of studies that have kind of maybe indicated that this is not happening. What this means more broadly, I can't say. I do think it makes me question whether this is an effect we should actually consider or not when we're determining how we're going to treat patients. But what about higher stage, non-resectable, but still not metastatic disease? So standard of care for stage 3 unresectable non-small cell lung cancer is the Pacific, assuming there are no actionable genomic alterations, with concurrent chemotherapy, radiation therapy, followed by immunotherapy with durvalumab. The INTEREST study wanted to see whether the addition of induction immunotherapy may improve outcomes in bulky stage 3 disease. This was a phase 2 randomized clinical trial. It evaluated 2 cycles of induction chemotherapy and immunotherapy versus induction chemotherapy alone in advance of CRT followed by consolidative immunotherapy. Of note, it does use toripalimab instead of durvalumab. It is a Chinese study, and when it opened, durvalumab was not readily available in the market, but relatively similar. Eligible patients had to have bulky stage 3 disease, so either 5 centimeter tumors or larger, or nodal size of at least 2 centimeters. Primary endpoint here was PFS. Median PFS was not reached in the toripalimab arm. It was 12.4 months in the chemo-only arm. Overall response rate was 77.8% versus 40%. Importantly, there were higher rates of grade 3 pneumonitis with the induction immunotherapy at about 11% versus 4%. Where I practice, we do sometimes utilize upfront induction therapy for very bulky disease in advance of chemoradiation in the hopes of making the disease more amenable to radiation therapy. And we will often utilize immunotherapy as part of that regimen as best systemic therapy. When we do so, it's always a topic of conversation at our tumor board, recognizing the theoretically increased risk of pneumonitis. I think this trial not only indicates that it might be a safe maneuver, but also an effective one, recognizing that it's only a phase 2, and it does use a drug not typically used in the US for this purpose. So, key takeaways. Neoadjuvant chemo IO improves 5-year overall survival, so does perioperative. Who knows which is better? Neoadjuvant targeted therapies are an emerging option. Immunotherapy is unlikely to improve outcomes when SBRT alone is indicated, and there is room for improving systemic therapy options in stage 3 unresectable non-small cell lung cancer. Feeney.
Any questions? All right, back.
Thank you. So thank you so much. Neoadjuvant therapy is out of the bag now. And one of the challenges that we had when it first started, and I'm glad I have some surgeons here, is we still have between 17% of patients and maybe 18% of patients in most trials not going for curative intent surgery. And so we're seeing a 10% overall survival with the addition of immunotherapy to chemotherapy, but we're seeing 17% of patients not making it to the operating room. And so I think the question as we adopt neoadjuvant therapy is always that challenge, making sure that those patients are ready. And I'm actually glad you presented the data at the end, because my question isn't whether or not we're doing neoadjuvant therapy, because I think the long-term benefit with these patients and us talking about doubling time for these cancers and saying get systemic therapy in because we know they're failing distant right now anyway, is the patients that we can't take to the OR, we're flipping to radiation. And you answered the question that I had at the end. So when you have that neoadjuvant patient that's failed, are you bringing it back to tumor board and discussing then jumping in with radiation with those patients then and then kind of flipping them?
Yeah, that's a really good question, and another one I don't think is well answered. So we do tend to do that. It has not, fortunately, been an incredibly common occurrence, but there are patients who, after 3 or 4 cycles, are progressing. If it's local, we have taken them to actually CRT followed by immunotherapy. The issue with that, of course, is that you're exposing to more chemotherapy on top of already having received pretty good doses with the neoadjuvant regimen. If they're failing more distantly, then we generally are not adding radiation and we're just doing systemic alone.
No other questions? North?
I'll try to jump in that discussion. It's a great question. You kind of distinguished in your talk resectable and unresectable. And as surgeons, that for us is kind of the main questions, and we drive our decisions based on different factors. But in your practice now with the advent of immunotherapy, how do you think that has changed? We're seeing in our practice that a lot of patients that we wouldn't have considered for surgery, potential candidates, and we're seeing patients with lymph node disease, clearing their lymph node disease and so forth. Where do you think this is going to end up, and should we give everybody immunotherapy and chemotherapy to start if they're candidates?
Yeah, it's a great question. So the original trials, again, were not designed to downstage. Patients were enrolled only if they had resectable disease at time of diagnosis. So we don't have good data for that. And that's why I say with NeoAdora and Al-Neo, it's an interesting case because there was a lot of nodal downstaging in NeoAdora, at least. Where I am at Ochsner, we present pretty much every patient that we're considering giving any kind of neoadjuvant therapy to at our tumor board with our surgeons present. I don't, Dr. Pettiford or Dr. Dozier, I'm not sure that we ever really have treated anybody with the intent of decreasing unresectable disease to resectable disease. Is that fair? Yeah. Yeah. Now, if that's a future option, I think for sure, but it's not something that we've been doing.
Dr. Millett, great talk. And actually, you didn't sound like Charlie Brown's teacher like you normally do in tumor board with all these fancy terms. But you had mentioned neoadjuvant therapy for stage 1A disease. How do you present that to patients and get buy-in from patients? You know, even, for example, based upon the ODORA trial, I would talk with patients with stage 1B disease about adjuvant Tagrisso, and sometimes even that is a tough sell. So how do you convince a patient to get neoadjuvant treatment with clinical stage 1A disease?
So we're offering stage 1. So the way that I practice, again, it's based off of kind of the metrics in the study. So if someone has 4 centimeters or greater tumor or node positive disease, I will offer them immunotherapy. If they have a stage 1B, I won't. So stage 1A, I say surgery. I don't do any kind of medicines in that situation. Now, in the lower stage disease, I do try to have an informed and non-Charlie Brown conversation with them to discuss, you know, the data is not as good. You know, the benefit seems to be driven by people with larger disease or node positive disease, and that's not you. But you have some high risk features, spread through air spaces, VPI, et cetera. And I discuss with them that, you know, we think that we cut everything out. And we hope that we cut everything out. Not we, you. I can't cut a steak. But we say there is a risk of micrometastatic disease. There could be microscopic cancer that our scans can't pick up. And I am concerned because of these reasons that could be in you. And there are patients who turn it down, but it tends to be the majority actually go with it.
Any other questions? Great talk. Thank you.